Of time, I think we'll get started for this evening. So thank you all for joining us on this Tuesday evening. My name is Madeline Jankowski, and I'm a sonographer in Chicago in the US at Northwestern University. I'd like to thank Agitated Solutions for sponsoring this webinar, and I'd like to welcome you all to our CME webinar, Under Pressure, Valsalva Maneuvers and Agitated Saline Studies. Tonight, I'm joined by Dr. David Messika, a cardiologist from Ottawa Heart, and we will be talking about the importance of Valsalva and bubble study challenges and give you some tools and techniques that can help to address these challenges. Thank you, Dr. Messika, for sharing your wisdom with us tonight.
Pleasure. Thank you, Maddie.
Following the presentation, you will have time to ask all the questions you may have. When you're asking questions, you can write them throughout the presentation using the Q&A button that's at the bottom of your screen. We will be answering them at the end of the session. We will also have opportunities for you to interact throughout the webinar in the chat function, which I see some of you have already been using. In order to get your CME credit for this webinar, be sure to complete the survey that's at the end of the webinar. A link will come up on your screen once we end this event tonight. And please make sure that your email is included as well as your registry number so that we can make sure to appropriately get those CMEs to you. Keep in mind, if you don't complete the survey, you will not get credit for this. So thank you again, and we will get started. Please enjoy. So we did some housekeeping already, Dr. Messika. I guess we will start off with a poll. So we want to get to know our audience tonight. So I'm thinking there may be sonographers, maybe some physicians or nurses. Nicole, can you put up the poll? Here's that. Who primarily agitates and injects the saline at your institute? So we want to hear who's usually doing that standard of care or helping to inject those bubble studies for you. So we'll give you a little time to answer.
The system is working well. I cannot vote myself, so I hope everybody can vote.
Yeah, I think the participants are able to vote.
That's good.
We can pull up, I think we can probably pull up those results now, Nicole. Wonderful. So really a lot of the sonographers are doing the injecting, but we see physicians coming in and also nursing staff. I'm curious to see who those other people are as well. So another kind of get to know you poll, who, while you're doing the injection and you're helping doing that Valsalva maneuver, who's primarily conducting that Valsalva maneuver at your institution? Is it again the physician, nurse? Is it the sonographer that's performing the scan or somebody else? All right. I typically perform the Valsalva at my institution. I'm the one kind of directing the patient doing that, but usually a nurse typically is the one helping me inject. So we can go ahead and put up those results too, Nicole. So this looks like a kind of an overwhelming sonographer is usually leading this. So great. So I think we have a lot to talk about tonight in terms of how to get that good Valsalva. So I will turn it over to you, Dr. Messika.
Thank you, Maddie. So my presentation will be more about the basics of things, and Maddie will give you some tricks regarding how to conduct that. Next slide. It's my disclosure slide. Next one. What I would like to discuss with you today is review the anatomy of the anteratrial septum, clearly define what is a PFO, why looking for a PFO is important in patients with cryptogenic stroke, and more technically, how to detect PFO using echocardiography. So, as you know, during fetal life, there is a communication through the PFO between the right and the left side, which after birth, this structure closes. What is important is to see on the right bottom that the PFO is not a hole is really a valve-like structure. And if you go to the next slide, you see better that it's really a valve-like. And based on the pressure, you can have communication between the two cavities. In the middle, you have the anatomy from a human heart. And what is important is that if in most cases, PFO closes spontaneously after birth, in 25% approximately of the population, it can remain open with prevalence, which is decreasing with age. Next slide. Another important anatomic feature to describe, and it's very important to have that feature for any report of patient with a stroke, is the anatomy of the intraocular septum, and especially the presence or absence of aneurysm. So the aneurysm is when the septum is bowing in one side in the RA or the left atrium. And the definition, you need to have this bowing for more than 10 millimeter to reach the definition of aneurysm. But sometimes, nope, sorry, you went too fast, Maddie. Sometimes the septum is very floppy and can bounce on both sides. And usually the definition for an aneurysm in that case is at an excursion of 15 millimeter. In the next slide, you have two examples. On the first left, the LV, the Mayowe, is on the left, and you can see a huge aneurysm bombing from the left to the right. In the right side, you have a very mobile and aneurysmal septum. You can see it's bouncing from both sides, a huge aneurysm. Next slide. And in many cases, in some cases, I'm a little bit frustrated by the imaging I'm receiving. And my impression is that we don't focus enough on the anatomy. And so, Maddie, how do you assess or how do you show your physician the anatomy of the intraocular septum? Do you have special views? You're using the zoom specifically for chamber, short axis? Which is your preferred view to demonstrate the presence of an aneurysm?
Definitely. I think if, while I'm kind of going through, especially if there's an aneurysm, and I notice it kind of first, usually in that parasternal short axis image, where we can see that interatrial septum kind of in the bottom left-hand corner of the screen. And that's really kind of where I usually start to see that. And you can do some type of, kind of color assessment from there as well. One of the really important views that I like to get is a really nice four-chamber view to really see what the maximal excursion of that interatrial septum is. I tend to zoom in on that left atrium and almost do a biatrial view so you can really tell if it's, switching sides, if it's fixed in one atria or the other. Sometimes I'll also slide a little more medial on the patient so that the interatrial septum is a little bit more, a little more horizontal and almost like I was going to assess it in a subcostal view. Sometimes I feel like that way I can also really start to see that anatomy as well. And if you have any other suggestions, I'd love to hear them in the chat as well. Yeah, subcostal and apical view is one that I'm seeing in there. Definitely from the subcostal view as well. Remember that that is where we're going to be the most parallel to that flow if there is a PFO or an ASD. And so typically we can pick it up there.
One of the key messages is that we should not limit ourselves to one view. And I think it's combining, like you mentioned, the short axis view, the apical for chamber, and the subcostal usually help us capturing the presence of an aneurysm.
Yes. Somebody else put in the chat, making sure to do some sweeps as well. So using that, using your techniques on your echo, doing a longer loop and maybe sweeping through that atrium, especially if you can't see it as well. Sometimes they're so thin and it's hard to visualize.
And ask the patient to hold breath. Sometimes.
Yes.
So why PFO is important to look at, especially in young adults? It's a major cause of stroke. You can see the major cause of stroke on the left side, atherosclerosis, LV dysfunction, arrhythmia. valvular heart disease, but PFO is one of the major causes of stroke in young adults. The mechanism for the stroke through the PFO is either paradoxical embolism from the right to the left, or sometimes in situ thrombus. And why we have discussed the aneurysm is that the combination of large shunt plus or minus an intra-atrial septal aneurysm are the high-risk features for stroke. Go to the next one. And so we have, in the literature, there is 4 parameters that can help describing high-risk features of PFO. One is how large is the PFO, how many bubbles are crossing from the right to the left. The second one is the presence of the aneurysm. And the 2 others are less relevant or less strong, which is the station valve directing the flow directly through the PFO. And this large carrying network can facilitate the development of thrombus. But if you have to remember 2 major risk factors for stroke, large PFO, aneurysm. Next one. And it has been demonstrated in all these randomized control studies. So we have 6 or 7 randomized control studies that have shown the benefit of PFO closure through transcatheter device compared to medical therapy. But if you see in the bottom, the benefit of the PFO closure is mostly observed in patients that have high-risk features of PFO, again, large shunt plus or minus intra-atrial septal aneurysm. When you don't have these high-risk features, the benefit of PFO closures seems much less. Next one. Here, one example of high-risk PFO. It's a TE. The left atrium is on the top, right atrium on the bottom. And you can see, even in 2D, even without color, that there is a large gap through the PFO. When you put the color, you see immediately that there is a shunt from the right to left. And on the right side, when you inject contrast, even without any Valsalva, you see a large shunt. What is important, and we will discuss that later on with TEE, is that you see that the bubbles are going through the PFO. So it's not only a right to left shunt, it's a right to left shunt through the PFO. Next one. And so now we have a question. So in our institution, we perform the bubble study in every patient with stroke less than 60. And I will be curious to see what is your guidelines in each of your labs. Maddie, what is
Well,
your...
we can put up the next poll.
Maddie, what do you do in your lab?
We really, I think a lot of stroke patients get bubble studies in our institution. There's not as many really guidelines that we follow in terms of age, and so I think in our institution, a lot of most all comers of strokes, as long as they're kind of ischemic and not the hemorrhagic ones, will likely get a bubble study.
Yeah, in our lab, it's 60, which is sometimes too rigid, because if you are 61, we don't perform it, which is
Oh, wow. Yeah.
yeah. So
We
I
can
like
go
the
ahead and put
flexibility.
up the results.
All stroke.
Okay.
It's quite
So
balanced.
fairly, yeah, but pretty variable.
Mm.
So, a lot of people doing it in all stroke patients, many doing it the same as you, just less than 60. But that's really interesting to see just the variability of what institutions are doing. Thank you, everyone.
The rationale for age is that it was one of the inclusion criteria for patients enrolled in the randomized control study, and the benefit is mostly proven in younger patients. So that's why there is in some lab an age limit
A guideline.
or a clinical assessment regarding treatment. And
Wonderful. All right.
and so we have this algorithm to assess whether the PFO or the stroke can be attributable to the PFO. And what we use is a ROB score. You can see that if you get points if you don't have any cardiovascular risk factors, if cortical and in fact are cortical based on imaging, and if you are younger, and as you get older, you have less points. And based on that, you calculate the ROB score. And if you have a ROB score more than 7, you are either possible or probable that the PFO is the responsible of the stroke. So if you have a ROP score more than 7 and high-risk features, again, aneurysm and or large shunt, you are in the category of probable. If you don't have this high-risk feature, you are on possible. If your ROP score is below 7, you can be in the possible categories, again, if you have high-risk PFO features, and unlikely if you have a low ROP score and no high-risk features. And you can see the hazard ratio of the benefit of the treatment is significant when you have a possible, you're in the possible categories, and it's highly significant in terms of benefit of treatment if you're in the categories of probable, meaning high ROP score and high risk features. One. So TTE is the first line method for assessing the PFO and the presence of a shunt. The sensitivity of color Doppler is very low, 20%. In my experience, I don't rely too much on the color Doppler, especially when you have the flow from the inferior vena cava, it's always misleading. But to assess the PFO, you need to perform a bubble study, first at rest, and after that, when you perform a Valsalva maneuver. It seems very simple, but you need to pay attention to the detail, and you need to perform it very carefully to get good information. The transthoracic is a first-line method, but you have also TE and transcranial Doppler. And each method, if you go to the next slide, have advantages and disadvantages. So sensitivity and specificity for transthoracic is around 80 to 90%. Sensitivity is lower for small shots. TEE is very interesting because, as we have seen, it can locate where the shunt is going through, so really through the PFO. The inconvenience of the TE is that it's very challenging to perform any provocation maneuvers. It's difficult to ask the patient to perform a Valsalva with a probe inside. And the most sensitive method is transcranial Doppler. Transcranial Doppler is very sensitive, but the inconvenience is that it doesn't localize where the shunt is going through. So transthoracic is a reference method, and we perform the bubble study. For that, you need, of course, an IV line. You need to inject something. Usually, we use saline with 90% plus 10% air, and some people are adding some blood of the patients. You can use also bacteriostatic agent. And after that, you need to generate the bubbles. Either you do that manually, but at least in Canada, we have a Health Canada approved device to generate microbubbles. Next one. And so the definition of a positive bubble study is presence of a shunt from the right to left through with the bubbles crossing through the PFO within the first 3 beats. And you can see here nicely that you have the bubbles crossing from right to left through the PFO. Next one. And you need to do that bubble study at rest, but you need also to perform provocation maneuvers. And the main one is a Valsalva. So usually we ask the patient to take a deep breath. After that, you ask him to perform a forceful expiration with closed airway for 10, 15, 20 seconds. And after that, to release. We can also perform a goal-directed maneuver. You use a manometer, and you ask the patient to blow against pressure, usually 40 millimeter of mercury for 15 seconds. In some time, you cannot perform any provocative maneuver, so you have to perform yourself the compression of the abdomen or ask the patient to cough. Next one. That's a goal-directed device that we use in our lab. You can see that you have a filter. The patient is blowing through the filter and asked to reach 40 millimeter of mercury for 15 seconds. The advantage of the goal-directed is that it's very standardized. Everybody is doing the same. And we have performed a randomized control study testing the goal-directed and the self-directed maneuvers, and we should have the result in the following weeks. Next one. So again, why it's important to perform a Valsalva is because the PFO cannot be seen sometime at rest, sometimes or quite often. And if you don't detect the PFO, you may not treat the patient appropriately, misdiagnoses the PFO, and causing recurrence of stroke. So what the Valsalva maneuver is doing? During the strain, you have an increase in the intrathoracic pressure. So with that increased pressure, you have a decrease of the venous return, and the pressure inside the right atrium is low. When you release the strain, the intrathoracic pressure increase rapidly. You have an increase, drop rapidly, sorry. You have an increase of the venous return. And based on that, you have an increase of the right atrial pressure that can become higher than the left and unveiling the PFO. So the next one. So the key for the, if you can go to the next one, Maddie, please. The key for the Valsalva maneuver is the release of the strain. When you have the decrease in intrathoracic pressure, the increased flow into the right atrium, increased pressure in the right atrium, and that can push through the PFO and causing the positive bubble study. So the key point for a good bubble study, of course, you need good bubbles first. You need good image quality of your echocardiogram, and it's very important to perform a timely injection. So you need to perform the release of the strain when the right atrium is fully opacified by the bubbles. And how to assess the quality, especially if you are not in the room and you just look at the images that have been acquired, you need to see first a good opacification of the right atrium. Ideally, what you want to see during the strain is that the anterior septum is bombing from the right to left, and you're, of course, counting the number of beats. And here, as an example, you have few bubbles at rest. The patient is performing the strain, and after the release. So on the two first imaging, you are mostly at rest. In the third one, you see that the anterior septum is bowing from the right to the left. And when you release, you have the huge shunt from the right to left. Usually we do one injection at rest and one during Valsalva. In some cases, I feel frustrated and I would like to have at least two, but I will be curious to know what you do in your own labs.
Thank you. And please feel free to put this in the chat if you'd like to say kind of what you are doing, how many Valsalva injections you're doing. In our institution, typically I'll perform a Valsalva or Valsalva again if I didn't feel like the maneuver was performed well. But typically that comes with if there's some kind of artifact that comes over my image. So if a lung comes over, if the patient kind of squishes their body and I can't see those bubbles, that's definitely, causes me to do another injection. Especially when there is somebody who we may know that there is a PFO or maybe has a fixed atrial septum. I may have them do it a couple times to really make sure that they are performing it well. Um, it looks like other people are also doing the same thing, two max. Some people say one at rest, one with Valsalva. Um, Other folks are using a cough as well. So I think all of those are really great things, but I think we just need to make sure that that whatever maneuver we're performing, that it's a good one.
And a question related to that, and we don't have that as a reader sometimes, is how good is the quality of the Valsalva? And something that would be good to have in the report, saying that a negative Valsalva maneuver, but average quality, for example, or good quality. I think it's something important to report.
Yeah, I think that's a great point to, and especially for those who, sonographers who may not be in the room with the cardiologist while this bubble study is going on, to put in a comment in the report, or if there's a tech comments that you can make, a note for your cardiologist saying, I don't think this patient performed the this wasn't a very diagnostic Valsalva for this and this reason, just so also they understand what was going on during the procedure. Awesome. All right. Keep
Okay.
going.
And so you mentioned that large shunt is a high risk features, and so you have to quantify the severity of the shunt. The definition usually it's at least 20 or 30 bubbles from the right to the left. It's very challenging to count. I don't know if anybody is counting, but usually we do a semi-quantitative assessment of the severity of the shunt and how many bubbles we think we are seeing. As any test, if you go to the next one, we have false positive, false negative. Among the false negative, of course, if you have poor injection, if you are not performing a proper Valsalva, you can underestimate the prevalence of PFO. And you can have false positive, meaning that you have a shunt, but not through the PFO, like in patient with an intrapulmonary shunt, or if you have an anomalous venous shunt that you can see right to left shunt, but not through the PFO. And next one. So what we have seen is that you need to combine hemodynamic and anatomy. So again, it's very important to report and describe the anatomy of the anterolateral septum and the presence or not of an aneurysm. We have seen the definition, more than 10 millimeter if it's only on one side, or if it's bouncing on both sides, 15 millimeter. And you need to perform provocation maneuvers with the Valsalva. And again, the timing when you have the shunt is during the release of the strain, when you have the decrease in the intrathoracic pressure, an increase in the venous return, increase in the right atrial pressure, and you can see the shunt. Again, it seems very simple in theory, but this injection and Valsalva have to be performed very carefully, and we need to pay attention to a lot of details. And I think Maddie will give us more insight into how to perform it carefully.
Great. Thank you so much, Dr. Messika. That was just a wonderful overview and really fantastic to see those cases, especially, while we're doing these bubble studies to make sure that we're performing these Valsalvas well. So I'm going to continue with some technical considerations, kind of from the sonographer's point of view. And here are my disclosures. So I wanted to start by putting up this schematic of really talking about how we perform a Valsalva and the timing of it, because as we heard from Dr. Messika, that timing is going to be really important. So I made this schematic up to help me kind of visualize when we should do each step when. So across this screen is the 10 seconds that they could be bearing down and then the release at the end. You'll see throughout that we'll have that patient start bearing down, bearing down. As you're doing that, you're going to maintain your imaging window. So you want to see that apical four-chamber image while they're doing their bearing down. As they start to bear down, we should start to visualize that interatrial septum shift into the left atrium, like we described before. I will say that, and we can talk about this a little more later, this doesn't necessarily happen with everybody, but I will say that it will, if you see this kind of phenomena happen on your echo, that does mean that you're doing a good Valsalva, but it may not happen for every patient. So I wanted to put that out there. So as you're bearing down, you'll start to see this interatrial septum shift. Probably halfway through your Valsalva, I would inject that saline. So you're already getting that nice pressure there. As you start to visualize, it may take a couple heartbeats to start seeing those bubbles. You'll start to see the bubbles come in and the RAO pacified. Once you see that, you'll have the patient release and keeping that imaging window the whole time. And I think that's one of the most challenging parts is really keeping that window. So this will be available to folks on the Agitated Solutions website and also other things, just so that you all have a reference for how to do that Valsalva. When I'm giving patient instructions, I really try to have them optimize their breathing for the image. So really, this is how the step-by-step on how I tell a patient to do a Valsalva. I'll instruct them to bear down just like they're having a bowel movement. I typically use that terminology, even though it's kind of weird and gross, but most folks, understand that a little more than, if we said, please do a Valsalva maneuver. I may have them pinch their nose and put pressure with their breath against that pinched nose, kind of like that, just helping to kind of close that pressure system and build that pressure. I've also heard folks say to instruct them to blow into the end of their fist like that, kind of like they're blowing into a straw. That may also help kind of build up that pressure. I tend to also count out loud because I may be scanning and doing things and I don't quite know how long they've been holding it. Also, so the patient understands how long they really need to hold that Valsalva. And then make sure to instruct them to release. And I typically say, try not to take a giant breath right after you do that release. If you can do some more shallow breathing, it helps the image. So again, how do we assess? We kind of asked this question a little bit, but how do we assess the quality of a Valsalva bubble study? So when you're performing them in your lab, and you do the injection or have the patient do something, how do you know that they actually did it? One of the things sometimes I use, like that pinch nose or the kind of the straw blow technique. I also may put my hand on their stomach and have them kind of press out against it. Sometimes that helps folks kind of, you know, understand kind of a physical thing to do. Dr. Masika, if you're ever guiding patients on doing Valsalva, how do you know that the patient understood your directions?
I like to do what you do, having my hand on the stomach to be sure that you have a good abdominal contraction. It's probably one of the best criteria I used.
Yeah. Great. Somebody else put in the chat, they do a practice run and watch for that bowing. That's also a really great idea. Also, so the patient really understands what they need to do before you do the whole injection. Yep, a lot of people say that they're doing a practice one. Excellent technique. So how we perform a diagnostic Valsalva, so in observing this intraatrial septum shift. So this is a long loop of a 4-chamber, and this does not have any bubbles with it, but I'm having this patient bear down, and we can see that interatrial septum starting to bow towards that left atrium. And then right about now, they did the release, and so it goes back. So really trying to optimize this image while they're doing the Valsalva so that you make sure to keep that image nice and clear while the bubbles are going in. You'll know if you performed it well if you see that interatrial septum bowing. So another thing that, as we talked about that you really need during a quality bubble study is a quality image. And so one of the things I tend to do is, especially if when they're bearing down, if the image really degrades, I tend to possibly slide up a rib space. I know that we don't like to foreshorten our images for LV, kind of assessing the LV. But while we're doing a bubble study, as long as we can really elongate the left atrium and see the interatrial septum, that should also help so that hopefully when they're bearing down, you may get a better image. Also using a little bit off-axis imaging, so maybe sliding a little more medial may help, just if the apical foreimage is poor. And subcostal imaging also can be used when there's no apical images present, but I tend to warn people about that when we're in the subcostal view, that right ventricle is on top there. It's really anterior. And if we remember, like even if we inject contrast, that contrast attenuates. And so we won't necessarily be able to see a positive bubble study maybe as well from that subcostal view. So I think use it if you really need to, but I think the apical 4 chamber is typical for acquisition. Oh, skipped a slide there. So, some of the challenges with imaging during maneuvers, especially the timing of injection, I think this can be really challenging, especially when you're having somebody else inject. And so, I wanted to show a few clips of kind of challenges and images that maybe weren't so good. So, oh, I keep skipping my slides here. So this bubble study over on the left-hand side, as we saw the initial beat acquisition, the bubbles were already in the heart by the time we started that acquisition. And so when I see that bubble study, I really don't know how many beats it was from when we injected to when this was a positive study. And so really making sure that, if you have that acquisition that maybe you didn't capture those bubbles coming in, I'll pull it to the beginning again. So we're seeing that really the whole right side is opacified by the time the acquisition starts. In this bubble study, I can tell, so they're having this patient bear down, because the image degrades a little bit here, bear down. And then they had them release, and then there are the bubbles. So in this case, we really just missed the timing of when to perform that Valsalva and when to do the injection. So in this case, I would have held that Valsalva longer until I saw all of those bubbles start to come in and then have that patient release. In this case, we had a loss of an image during a Valsalva. So this, I'm sure we've all seen, this happened to our studies before where the patient takes a big breath. But then we saw after that lung came back over, this study is positive. So really understanding that we need to see the whole ventricle throughout that Valsalva to make sure that we are seeing the timing correctly. And so one of the things that can help is going, like I said, to a more medial view. So this was a really nice study where they're performing a Valsalva. We're seeing that left atrium bowing, and then they had the patient release. And this was a negative study, a beautiful negative study, but I really liked how the sonographer went a little more medial to be able to show really the elongation of that the interatrial septum and the left atrium. So great job on that sonographer. Here we can sometimes see when just we have really poor bubbles. So here the bubbles are entering. I'm sorry, my clip is a little slow here. So there are the bubbles. If you're saying, Maddie, where are the bubbles? They're barely visible. So one of the things that we really need for these bubble studies is really high quality bubbles. So whether that's making sure that we are, agitating enough or injecting fast enough, making sure your line is, doesn't have a bunch of tubing to it. There can be quite a few things that can make bad bubbles. And so really making sure that that opacifies well, makes its way up to that interatrial septum here so that when we're performing that Valsalva, the bubbles have a chance to cross. So another consideration is Valsalva. We use this for HCM as well. And so it's the same maneuver that we're using, but I really just wanted to point out the differences between the maneuvers in these two pathologies. And so here I've included a clip. This patient has HCM and we can see that SAM. But when we're doing a Valsalva for HCM, we're really focusing on the straining phase while they're bearing down and looking to see that LVOT gradient going up. But when we're doing a bubble study, it's really focusing on the release part of that Valsalva. So that's when we've increased those right atrial pressures and then we're letting it go to see if that flap opens up for that labile shunt. So yes, same maneuver, but we're focusing on different parts of it for these two pathologies. And I think it's just important for both is to have them bear down hard and then just make sure it's long enough for that about 10 to 15 seconds. So the last case I wanted to show was when self-directed Valsalva wasn't enough. So Dr. Masika had brought up the study about and that they're using goal-directed Valsalva at their institution, which I put a little picture of up there. These were given to me by a colleague of mine down in North Carolina, where they're using the sphygmometer very routinely. So here we see the agitated saline study just at rest over on this left-hand side, where it was negative. But then when we had that patient blow into the device, we were able to see. So we're not really seeing too much of that bowing, but we see that positive shunting there. So I'll play that again. So here they're blowing into this machine and then the release, and that's when we see those bubbles come through that PFO. So a really nice just case of demonstrating how this goal-directed Valsalva can really help us in making this more of an objective procedure. And Dr. Masika, I'm curious just on your experience with goal-directed Valsalva and bubble studies, have you seen that the interatrial septum shift more, do you think?
Um, Difficult for me to answer because results are under embargo.
Oh, yes. Okay. Yeah.
But
So I'm,
it seems the main advantage is that it's very standardized. You know for sure that what the patient is doing. Explanation is relatively easy to give. You just blow and you reach 40. Um, Regarding result, I will tell you more in a couple of months.
do you find it's pretty easy for the sonographers to, put this device together and have the patients perform it as well?
It was relatively easy to do. I don't think it's very you need to put the machine close to the echo machine, but it's not a big system. And for now, if we have done that manually with our own homemade device, I'm sure we will see uh, smaller devices that you can put just asking the patient, like was used for asthma, uh,
Yeah.
the the flow test.
Yeah.
You can imagine having similar device for that.
Exactly. Yeah, when I've done this at my institution, we've also kind of MacGyvered together a device. But I found it really helpful to use the blood pressure cuffs that have the bigger faces to it also so that the patient can really see when it's going up to 40. Thank you so much. So that ends our webinar here. So we will take some time for questions. We've got about 15 minutes. And I see that we already have some questions in the Q&A section. Feel free to put some more in. All right. So I may pose a few of these to you, Dr. Masika. Is there a subgroup with low rope score but high risk anatomical features that still benefit from closure?
So if you have a low ROP score, mean less than 7, but if you have high risk features, again, aneurysm and or large shunt, you can be classified in the category of possible. And possible, it means that you are benefiting from the closure. So yes, if you have low ROP score and high risk features, you can benefit from the closure.
Great. Here's another one. Does semi-sedated TEE systematically underestimate intermittent or large PFO shunts because provocation is less effective than during the awake TTE?
So yes, because it's quite complicated to perform a good Valsalva with a probe inside. So the sensitivity and specificity might be decreased because of that. But you can still achieve relatively good Valsalva,
Mhm.
but it's more challenging.
Yeah, some of the TEs I've been a part of, obviously the patient is not awake enough to perform anything, but some of them, have been pretty mild MAC that the patient can try to perform something, or at least a belly press.
So
Here's another question. Is optimized contrast TTE is it the gold standard for physiologic provocation?
So what we have as a gold standard for the PFO detection is a transthoracic with contrast, yes. And when we say with contrast, it's a bubble study, not LV contrast.
So
So yeah,
transthoracic with bubble study or TEE?
so transthoracic is the first line,
Yeah.
so sensitivity and good specificity. In our institution, we perform systematically uh, before any PFO closure a TEE in the echo lab to confirm that the shunt is through the PFO and have a better look at the anatomy. But if you have good quality transthoracic, usually it's just a confirmatory test. And I'm sure not every institution is doing that before PFO closure.
Great. All right, let's see. Can patient-specific factors, like BMI or lung function predict how many injections you do?
I don't know if it's predicting how many injections, but can predict the quality of what you can get. Uh, so the different parameters that you should look at when you do PFO is first to have good 2D image quality, and we know that obese, COPD are associated with lower image quality. And after that, some patient again with obesity or not appropriately performing the Valsalva is another reason for having a poor bubble study. It's a combination of the 2D images plus how good is the Valsalva.
Do you ever find that, in your institution, and I'm curious about the audience too, if the bubble study is positive at rest, do you continue on with a Valsalva?
Good question. If it's just a small shunt, yes, we usually do. If you already have a very large shunt at rest and you're sure it's through the PFO, I don't see the reason for doing a Valsalva. It might even be dangerous because you can increase the degree of shunt and have some TIA. So if it's a small shunt at rest, yes. If it's a large shunt at rest, no.
Great. Is there any septal motion grading to score Valsalva adequacy?
It's a good idea.
Yeah.
I'm aware of. I don't know if you are scoring the quality, but it would be good. Even if it's not quantitative as a scoring system, again, that we report in the echo report the quality of the Valsalva because you're in the front line with the patients. At least in our lab, we are not with the sonographer when they're performing the Valsalva. Usually it's two sonographers together. And you have to read the echo, but not knowing how good or bad is the Valsalva, which can have huge implication for the patient. Because if it's not good quality for any reason, sometimes you do your best and you cannot have a good bubble study. But for me, it's an incentive to suggest a T.
Yeah, I think here too in my institution as well, and I think we will typically, I don't think that right now I see anything really grading to score Valsalva adequacy, but I could see a real benefit to that. And I also think that it would probably be good to report, well, if it is a bubble study that you're reporting, if there was septal movement to say that to say we know that there was a diagnostic Valsalva because we saw septal movement. Is there any variability with positioning? I'm
Not
guessing like
aware of.
positive, negative, I'm assuming.
Yeah. Maybe I'm thinking about the plateau orthodopsy syndrome, where you have a shunt that can be only seen with a change in position. But for the PFO itself, I'm not sure that the position should affect the rate of detection. Not that I know. Outside
Yeah.
of the plateau orthodopsy syndrome.
Yeah, I really haven't found, I guess I haven't really tried scanning in too many different positions. I know that we have done, bubble studies where we will do it pre and post exercise for a stress echo. So that I think that's probably the most, different position I've done it in before.
A stress bubble study.
Yes, stress bubble study, exactly. It was more of a stress test for me, I think. Is factor five a contraindication for PFO closure?
Factor five for coagulation.
Um, I'm not quite sure. In fact, yeah, is factor five a contraindication for PFO closure? I don't know if I know.
I'm not sure if it's factor five for in the cascade of coagulation. I don't see why. Uh, I'm not sure to understand the question, so I don't know.
All right. Yeah, I'm not quite sure what if this is relating to maybe a um like a genetic disorder. I'm not quite sure. We'll move on to the next question. If whoever wrote that would like to just put in and clarify a little more, we can happily answer your question. Oh, yes. So more like a genetic condition, factor five
The
Ledian?
planting disorder. Okay. No, if you have a deficit in factor five, and no, I don't see that as a contraindication for the bubble study. After that, you have to make a clinical judgment if the PFO, if it's positive, is the cause of the event, or if it's a coagulation disorder that it's responsible for of the clot. But it's more a clinical decision. In terms of testing itself, it's not a problem. You can do it.
Yeah. But then for closure, there would probably be different, other considerations for that patient.
If you're at risk of clot and put materials inside the heart, of course, you will have increased risk of clot on the device.
Mhm. All right. I'll answer this one. Which is easier to scan, prospectively or retrospectively for bubble studies? Um, my preference is to scan retrospectively, so that I can make sure that I'm capturing that when the bubbles enter the heart. Really just the timing of when, to make sure that the timing links up with when the nurse or whoever is doing the injecting. I tend to do that retrospective. Also, that gives me the ability, usually on your machines, you have the ability to kind of do a select all. And that typically can give you more than the 20 beats that is allowed on one capture. So especially if you have a patient that, it's you got a tricky IV or something, you're just trying to do the timing. I just want to make sure I'm gathering all that information. I will say if you do it prospectively, just make sure to work really closely with your nursing staff. And I would say, I typically do like when you say, okay, I'm going to inject, I press it when they say, right about before they were going to actually press the plunger. That way I'm making sure that I'm seeing those bubbles enter the heart.
You don't want it's like movie. You don't want to miss the beginning.
What was that?
It's like a movie. You don't want to miss the beginning.
Exactly. Yeah. You don't want to miss the beginning, don't want to miss the end. So, and also for prospective, that if you have a late shunt, it may cut that off. If your Valsalva timing or the timing of the injection was off a little bit, you may miss some of those late bubbles. So, again, I typically do it in retrospective scanning, but you can do it in either. Somebody asked, are we doing bubble tests on pregnant women or breastfeeding women in your lab?
Breastfeeding is not an issue. Pregnant women, um, usually we don't, because there is always a risk of, even if it's small, of TIA, and you will not perform the closure during pregnancy anyway. So usually we don't.
Our us too. Typically, yeah, if they're breastfeeding, yes, we would typically perform a bubble study if they're pregnant. I think it would be more of a risk, benefit, seeing, if there was something they were really trying to answer. But again, like Dr. Masika said, they wouldn't close it during pregnancy. All right, and I think. Does anybody have any other questions? I'm just going to check the chat. Oh,
There's
yep,
one
we got
with
a
the
couple.
MR.
Should we be doing bubble studies with Valsalva maneuvers for patients that have a TIA?
Yes, TIA and stroke should be considered similarly in terms of looking for PFO. If you are in a young population, you have a TIA or stroke, you need to perform a bubble study. And based on the ROP score after, if it's the TIA is due to a PFO, you perform the closure as well.
Great. Um, here's one more. What about pacemaker leads or a long eustachian valve causing false negative studies by obscuring the bubbles to reach the septum?
I don't think pacemaker will cause that. I don't know what you think, Mehdi. Should not cause any, should not impede the contrast to go to the tertiary septum. The eustachian valve could, but sometimes it's even the opposite. It's directing the blood towards the endotracheal septum and causing more PFO. So could be even so pacemaker, no impact. Station could be increasing the probability of having a PFO, but it's not a false positive. It's a true positive. It's the anatomy of the patient.
Yeah, and I would say I find this to be sometimes a challenging part of bubble studies when you have really prominent either like vena cava flow or eustachian valve, and you have that appearance of like no bubbles in a little part of the right atrium. And so really to try to, either to do those injections, I've heard of some people kind of doing a compression on the patient's like maybe it's a belly press so that they're compressing the vena cava a little bit, but I haven't really seen too many techniques on how to get rid of that.
So if you have the washing due to if you're in a cava, you're stuck.
Yeah. All right. And then just the last one, is performing a Valsalva maneuver during a live TEE possible? I would say probably yes.
Yeah, it is. The issue is that some people can perform good Valsalva, some less, because of sedation and because of the probe.
Yeah. Well, great. Well, I think that's it for questions. If you have any more, please feel free to reach out to us at agitatedsolutions.com. Thank you so much for joining us this evening. Please don't forget to complete the post-event survey so that you can get your CME from Agitated Solutions. Our next webinar is going to be From the Reading Room, Confusing Bubble Studies. And that's going to be on June 3rd at 7 p.m. Eastern Time. And the registration link will be in your follow-up email, but we also have a QR code here to scan. Also, please make sure to check us out on the website, agitatedsolutions.com, or follow them on LinkedIn or Meta. But we really appreciate all your time and joining us this evening. Thank you, Dr. Masika, for being here.
Thank you,
And
and
good
thank you,
evening,
Madeline.
everyone.
Good evening.